Evaluation of the limping child. Gait observation should be done where there is plenty of space and the ability for the child to move without changing the gait due to obstacles or being observed. It is important to understand the normal immature gait to differentiate pathologic alterations. In stance, the feet are widened to support the body. The knees are more flexed and ankles more dorsiflexed in stance. Single leg stance cannot be maintained for a significant amount of time. Physical examination should be done gently and quietly on the parent's lap. The examiner should attempt to localize the area of pain with palpation of the pelvis and trochanters. Move distally to palpate the distal femurs, tibia, and feet. Look for knee and ankle swelling. Move the patient's hips through range of motion, including flexion, abduction, internal and external rotation. Keeping the patient comfortable while on her parent's lap helps improve the ability for the examiner to localize the area of pain. Move through palpation, starting proximally, and move distally. Look at the patient's face to inquire as to whether or not this causes any pain. Then move the patient's hips through passive range of motion. Flexion, abduction, as well as extension, internal, and external rotation can be performed, again, keeping the patient happy while on her parent's lap. 2 helpful tests include, first, the prone examination. Localize the area of pain by palpating the back and throughout the lower extremities, as previously occurred on the parent's lap. Move the hips through range of motion in extension. Flexion, extension, abduction, adduction, and internal and external rotation can all be performed well from this position. For the younger child, this is best done with the child being held by the parent chest to chest with hips fully extended. Here, extension, abduction, as well as internal and external rotation can be performed, again maintaining the patient's comfort. A second helpful test is the crawl test. If the child will not stand, try to entice the child to crawl. If the child can crawl, this narrows the location of pathology to the tibia and feet. Imaging studies can now be limited to those areas. Here the child is seen easily able to crawl. This locates the pathology distal to the knee. If the child was unable to crawl secondary to pain, this would indicate pathology above the knee. When a child is able to crawl but not walk, the most common diagnosis for a limping child would include the following: a minimally displaced tibia fracture, also known as a toddler's fracture, a proximal tibia fracture, which is most commonly sustained in a trampoline injury, a distal tibia fracture, which can occur if the child is dropped. If the child has an antalgic gait, obtaining radiographs may show a foreign body in the foot, in this case a sewing needle. And finally, this patient presented with a limp and associated fever. The MRI was significant for distal tibia osteomyelitis.